And welcome back, everybody. Let's go ahead and set the tone right away. Today we are covering Chapter 14, BLS Resuscitation. And today's session is really about all the life-saving essentials that we're going to call basic life support. Okay, so from the moment you step off the rig, BLS is your first best chance to keep oxygen and blood flowing to a patient's brain and heart until more advanced care can actually catch up. So over the next hour or two, you're going to see why every compression, every rescue breath, and every decision that you're going to make in these first critical minutes really creates the foundation for patient survival. So think of BLS resuscitation as essentially the EMT's playbook for buying more time, right? So circulating oxygen, preventing brain damage, and really opening the door for recovery. So by the end of this lecture, you'll not only know each maneuver, you'll understand the science and the timing behind them so you can perform with purpose, with precision, and with confidence. So before we actually dive into the techniques, it really helps to see the bigger educational target. So the National EMS Education Standards really group BLS under the shock and resuscitation competency. So you're expected to master the causes and physiology of respiratory failure, shock, cardiac arrest, and really to be able to manage each phase from the first chest compression all the way through post-resuscitation care. So that really means understanding why hypoxia and ischemia actually occur and how high-quality CPR actually mitigates them, and really when to transition from BLS to ALS without losing those precious seconds. So today we really weave those standards throughout the entire presentation. So everything you practice really maps directly to the performance objectives that you're going to be evaluated on, both in class and in the field. Now, BLS actually has been, and then we're going to refer to BLS as BLS resuscitation. So we're talking about our CPR, okay? But BLS has essentially been around since 1960, but it hasn't really stayed static. So every 5 years, the International Liaison Committee on Resuscitation really sifts through the newest research and the issues and updates the current guidelines. So most recently in 2020. Now, and we're actually expected to have new revisions in the coming months, I think in October of 2025. So now, why do we need to have these constant revisions? Well, the real reason is because high-quality evidence shows even small tweaks like faster compression rates, deeper depths, fewer pauses, that can actually translate into measurably higher survival and neurologically intact outcomes. So our job is to turn those data-driven guidelines essentially into muscle memory so that when every little second matters, your hands already know exactly what to do. You want to push hard, push fast, minimize interruptions, and defib early. So this lecture is going to connect those research insights to the practical steps on each of these slides moving forward. You really need to think of BLS as everything you can do without, poking, cutting, or medicating, right? So it really starts with the airway positioning, progresses to rescue ventilations, and then at the end of it culminates into chest compressions. And you can initiate the entire bundle with nothing more than some gloves and a pocket mask. So these non-invasive skills treat three immediate issues: airway obstruction, respiratory arrest, cardiac arrest. So when they're performed correctly, they maintain oxygen delivery long enough for ALS procedures, or sometimes eliminate the need for them altogether, as in a classic choking or near drowning cases where your timely BLS alone can actually reverse the arrest. Now, your assessment mantra, so to speak, is still airway, breathing, circulation. Okay, your ABCs. But notice how the order can flex once a true cardiac arrest is confirmed. So until you know that the heart has stopped, you want to clear the airway, assist breathing, and then check pulses. But now, if pulses are absent, you're going to really immediately flip to the CAB sequence. Now, in CAB and CPR, we're talking about compressions, airway, breathing. Okay. Now, why do we do that? Now, the real reason is because the blood already inside the lungs really holds enough oxygen for a minute or two, and circulating that oxygen within the chest compressions buys time while you open the airway, set up ventilations. So you miss that priority shift, and valuable myocardium and brain cells are going to be injured, damaged, and then finally die while you're just waiting for that oxygen. Now, the science here is fairly blunt. Seconds really separate recovery from irreversible damage. Okay, your brain cells actually begin to die after roughly 4 minutes without oxygen, and suffer likely permanent injury by 6 minutes. Okay, so that gives you a razor thin window to recognize apnea, pulselessness, and to aggressively act. So every hesitation, adjusting your equipment, debating rules, it really burns irreplaceable neuronal time. So you need to train your eye to spot agonal gasp. You need to feel for those absent carotid pulses and sudden collapses immediately, and launch compressions within 10 seconds at most of confirming cardiac arrest. Now, here we have a graphic that really dramatizes those numbers visually. Okay, so at 0 minutes, the brain is irritable, but it's viable. But by 4 minutes, damage is possible. At 6, damage is likely. And then by 10, it's generally irreversible. Okay, and again, that's all about your cellular death. So use this visual every time you teach, bystanders, because when a lay rescuer grasps how little time they have, they're going to be far more willing to start hands-only CPR before you arrive. And again, as we talked about in Chapter 1, public access and public education with basic CPR and first aid is a very important aspect of being a pre-hospital care provider, because we want to make sure that the public can actually initiate care before we get there, because a lot of times our response time is going to be in that 8.5 minute range, and if that patient doesn't have circulating blood within those 8 minutes, there's a highly unlikely chance we're going to get ROSC, and that patient's going to unfortunately not be able to survive. So that early bystander link really sets the table, so to speak, for professionals like BLS to initiate care. Now, so cardiopulmonary resuscitation, okay, that's what we're talking about here. That's the primary and primary element, and that kind of sounds fairly technical, but again, let's break it down into just medical terms. So we have cardio, right? So that's referring to the cardiovascular system. More specifically, we're talking about the heart, which is the pump, okay? Then we have pulmon, okay, or pulmonary, okay, and that's referencing the lungs, okay, and that's really to get air from the environment so we can get that oxygen, and then we're also exhaling waste products. And then we have resuscitation. That means to bring back or to restore life in this case. So CPR essentially is using external chest compressions to mimic the heart squeeze while providing rescue breaths, or passive oxygenation to load that circulating blood with oxygen. So effective CPR really preserves a third of normal cardiac output. So rarely enough to wake a patient, but plenty to keep the brain and the coronary arteries viable until a defibrillator resets the rhythm, or ALS drugs can stabilize the myocardium. Now, those steps are really the backbone of every algorithm, okay? So these steps. So restore circulation with at least 100 to 120 compressions per minute at a depth of 2 to 2.4 inches. Now, this is, again, we're speaking more to our adult patients. You need to open the airway via head tilt, chin lift, or jaw thrust. And then we need to restore breathing with, two gentle 1 second ventilations that make the chest rise. Okay, the order here really matters. Circulation first and arrest, because coronary perfusion coronary perfusion pressure builds only when compressions are continuous and deep. So, and then also ventilations that are too forceful, too frequent, or delayed by equipment fiddling, that actually takes away that pressure, and it's going to lower the survival odds of that patient. Now, the textbook photo here really reminds us about the whole CPR process. Okay, so you begin with the tap and shout, scan the chest, feel for a carotid pulse, and all within 10 seconds, and then you start your CPR. So if you're not sure you feel a pulse, you need to assume there isn't one and begin compressions. A false positive pulse is going to waste time. Really, compressions on a beating heart are rarely harmful, but not compressing on an arrested heart, that could be fatal, and that will be fatal. So pair that speed with scene delegation, right? So one rescuer dials 911, another begins compression, the third goes to get an AED. So all the links of the chain of survival are engaged in parallel rather than in a series. Okay. Now, when we talk about basic life support, right, BLS, we're talking about what EMTs are trained and authorized to do, okay, without advanced tools or medications. That includes manual airway management. That includes, rescue breathing, chest compressions. Compared that to advanced life support, or your ALS, which introduces interventions like cardiac monitoring, IV drug therapy, advanced airway. But here's the thing, just because ALS has more tools doesn't mean BLS isn't critical. In fact, BLS is actually the foundation of every resuscitative effort. So if BLS isn't done correctly, if the compressions are too shallow, too slow, interrupted, then no medication or intubation is actually going to fix the damage that is being done. You really need both, okay? And then they need to work in tandem of each other. So think of it this way: BLS is the support beam that's really holding everything up, while ALS is constructing the next level of care. Now, let's look at the American Heart Association chain of survival. Okay, so this visual representation of 6 critical links that must occur in order to really maximize a cardiac arrest patient's chance of survival. The chain starts in the community and it's going to extend all the way through the hospital discharge. Missing even one of these links is going to weaken the entire system, right? So the chain itself includes recognition and activation. So that's going to be calling 911 right away. Immediate and high quality CPR. So that means we begin compressions before anything else. Rapid defibrillation, so early AED use for our shockable rhythms. Effective EMS response, so what we bring to the table with oxygenation, airway, continuing CPR. Advanced life support and post-arrest care, so this is usually going to be done in the emergency department or the intensive care unit. And then lastly, recovery, right, where the patient receives long-term physical and emotional support, right? So you'll notice that CPR is the second link, meaning that you are really the bridge between early recognition and defibrillation. So without you, the rest of the chain is going to simply fall apart. Now let's break down each of those links a little bit more so you can really fully understand where EMTs fit in. Okay, so now recognition and activation. So this often depends on lay people. Okay, so just members of the public. But when the 911 dispatcher picks up the phone, they can actually guide that caller through CPR instructions, and that's going to close the gap until EMS arrives. You have your EMS, you have your immediate high quality CPR. So CPR isn't just about going through the motions, it's about compressing hard and compressing fast. And again, at least for our adult patients, 100 to 120 compressions per minute at a depth of 2 to 2.4 inches. Now that alone can actually double or sometimes triple survival rates of our patients. Then we have rapid defibrillation. So with an AED, an AED is our patient's best chance of getting their heart back into what we call a normal rhythm, especially if they're in ventricular fibrillation or pulseless ventricular tachycardia. Then we have our basic and advanced EMS care. So this simply means, we're going to continue on doing CPR. We're going to manage their airway, and we're going to transport to the more appropriate facility. That's us and our ALS partners really working in sync with each other. Then we have our ALS and post-arrest care. Okay, this includes everything from advanced airways, cardiac medications, therapeutic hypothermia, and really ICU level type monitoring of that patient. And then lastly, of course, we have recovery. And this is often overlooked, but it's just as important as the other links in the chain, because it can really take months or even longer for recovery. And it's why we have to fight so hard in the field to get the patients to that final step. And really, in short, every one of these links depends on really a smooth, coordinated response, and it's really going to start with you as the EMT. Now, before we actually start compressions, you have to be sure it's safe to do so, right? So just like with any of our assessments. So that's why the scene size up should always come first every single time. You're going to look for hazards, right? Are there electrical wires exposed, traffic, bodily fluids, any sign of where the environment can actually cause harm to you or your crew. Next comes the primary assessment, right? So you need to approach the patient, tap and shout, "Are you okay?" If there's no response, we immediately check for breathing and a pulse at the same time. We're gonna call for help, right? So this whole check should really only take about 10 seconds, right? At least a minimum 5, no more than 10. You don't want to waste time. So if there's no pulses, you immediately begin chest compressions. And also remember that cardiac arrest calls, they really can be chaotic. So designate roles early on. One EMT should be in charge of doing compressions. Another one prepares the AED, and someone else manages the airway and ventilations. So planning these assignments before arrival can actually make a huge difference when every single second counts. Now, when it comes to BLS, it's really important to remember that adults and children arrests they arrest for very different reasons, okay? In adults, cardiac arrest is usually a primary cardiac event. Think a heart attack, a sudden arrhythmia, or some type of other cardiovascular failure, right? And that's why we focus on compressions right away with our adult patients. But with infants and children, most cardiac arrests start as a respiratory problem. So the child stops breathing, their oxygen levels plummet, and eventually the heart gives out. So that means our approach for these kids must begin with opening the airway, delivering effective ventilations, because it's the oxygen deprivation, not a sudden cardiac event, that's going to trigger the arrest in most of your pediatric cases. So for adults, you're going to think CABs in terms of CPR, so compressions first. For kids and infants, while compressions are still critical, airway and breathing often comes into play much earlier. That distinction really shapes just not just the order of interventions, but the urgency of getting ventilations right. So here again, we're looking at an image of the tap and shout. Now again, per American Heart Association, that's going to kind of be your go-to painful stimuli of the tapping. But again, we can, as an EMT, we can use other elements like the trapezius pinch, supraorbital rub. Some protocols allow the sternal rub, but again, we're trying to have a noxious stimuli to cause some type of response of the patient. But here, we're going to focus a lot on the tap and shout per AHA standards. Now, how you're going to do it, you just firmly tap on the patient's shoulders, loudly say, "Hey, buddy, can you hear me? Are you okay?" And this is the same for adults and peds. For infants, instead of the shoulder, you're going to gently pretty much flick and tap the soles of the feet. And if they don't respond, you immediately move on to checking breathing and the pulse at the same time. So it's important that you don't waste any time. The entire check, responsiveness, breathing, and pulses really should not take more than 10 seconds in total, okay? If there's no definitive pulse or you're unsure, you assume cardiac arrest, you start chest compressions immediately, right? Because that speed matters. You're not doing a full head-to-toe assessment. You're simply asking, hey, is this person breathing adequately? Do they have a pulse? If not, you start acting. Because really, hesitation in these first few seconds is what's really gonna kill outcomes later on. Now let's kind of talk about the AED for a bit. So one of the most powerful tools in your BLS toolbox, okay? So when a person is in what we call ventricular fibrillation or pulseless ventricular tachycardia, no amount of compressions will reset that rhythm, okay? Only defibrillation, and defibrillation is like a large electrical shock, Okay, and that's what can actually fix it. American Heart Association makes it clear, early defibrillation is the single most effective ventilation or interventions rather for a shockable cardiac arrest. So the chance of survival drops by 7 to 10% for every minute defib is delayed. So that's why AEDs need to be on scene and on the chest really fast. So if you witness a cardiac arrest, say someone collapses right in front of you, you should prioritize the AED immediately. Power it on, attach the pads, follow the prompts, and if the arrest wasn't witnessed, you really want to start CPR, then apply the AED as soon as possible. Either way, compressions and defibrillation, they go hand in hand. Now, when it comes to pediatric patients, there are a few key AED considerations. If the child is between the ages of like 1 and 8, so typically 1 in puberty, and the AED pads, the AED has pediatric pads and a dose, what we call a dose attenuator, you're going to use them. These really reduce the shock energy to a safe level for those smaller bodies. But again, if you don't have pediatric pads, you're going to use the adult ones, okay? Don't delay defibrillation just because the ideal gear isn't available. Instead, you're going to apply those adult pads using the anterior-posterior placement, one on the chest and one on the back, okay? So what matters really most is that the shock gets delivered, okay? Also, in our pediatric cases, you want to perform 5 cycles of CPR before applying the AED, okay? Especially if it's an unwitnessed arrest, because again, kids usually arrest from hypoxia, not a primary cardiac issue. So you want to oxygenate first and then defib if needed. Now, using the AED is generally straightforward. Again, you turn it on, you follow the prompts, all as well. But there are special situations that require a bit of extra care. So first up, you might have your pacemakers or implanted defibrillators. So these devices actually sit just beneath the level of the skin, typically in the upper left chest. You'll feel like a hard bump, but if you see that you place the AED pad at least 1 inch away, so you don't interfere with the shock that internal device is actually working on. Okay, don't place the pad directly over it because again, it can also reduce the shock effectiveness or even damage the internal device. But again, that's only if it's planted. Again, follow the manufacturer's recommendations on AED placement, so follow those diagrams. But typically speaking, your AED patches go on the upper right chest, bottom left chest, so that internal pacemaker defibrillator shouldn't be an issue, but just in case it is, again, 1 inch away. You could also have wet patients, so patients who are submerged in water. Again, water is a good conductor of electricity, so if someone is submerged or soaking wet, you need to get them out of that water and dry them off, dry their chest, and then apply the pads. Don't waste time completely drying the body. Just get the chest area dry enough so the pads stick and the shock travels where it needs to go. And then you might have what we call transdermal medication patches. These can interfere with the shock delivery and may even burn the patient's skin. So if a patch is in the way of a pad placement, you're going to have your gloves on already. Peel it off, wipe away any residue of that medication before you apply the actual pad. So for CPR to actually be effective, the patient has to be lying flat, face up on a firm surface. So that could be the floor, a stretcher, backboard. But what doesn't work, right? A couch, a bed, a large pile of clothes. You need to actually move that patient off of that unstable foundation, because compressions on a soft surface, they don't generate the pressure needed to circulate blood. So if you find the patient crumpled or face down, log roll them into a supine position as a full unit, trying to do your best to protect the spine if you suspect a trauma. Ideally, you'll get them on a backboard or a hard floor with plenty of space around them for you and your partner to work with. If they're in a tight space like a car or a bathtub, you may need to actually reposition them completely before you can begin compressions. And that is going to take a few seconds, but again, it's going to be worth it to be in the proper position to provide effective compressions in CPR, because poor CPR on a soft surface is almost the same as doing no CPR at all, because you just got to think about all the cushion that you have on that sofa, on that mattress, as you push on the chest, you're not compressing the chest down, you're compressing that whole unit of body downwards into the sofa, into that mattress. So you're not compressing that heart. And we'll cover that more in lecture, or lab rather. So now here we have one of the most time-sensitive parts of your initial assessment, and then because you've already tapped and shouted, there's no response. You check for normal breathing and a carotid pulse at the same time, and you do it quickly. Okay, you need to know, hey, do they have a pulse? Are they breathing? If they don't, CPR protocols indicated. So the entire check, again, should not take more than 10 seconds, but at least 5 seconds to make sure you felt something. No, you didn't. So you can visually scan the chest for movement. What I always like to do, I like to look, listen, and feel. I'm looking for rise and fall of the chest. I'm listening for air come out the mouth. I'm feeling for air, exhaled air past my face. Okay. Is the chest rising and falling normally? Okay. Do you see gasping, agonal, or is there nothing? At the same time, you're feeling for that carotid pulse by sliding your fingers just next to the trachea, in that groove between the sternocleidomastoid muscle and the larynx. And then again, you're using your pads of your fingers, not your thumb, and make sure not to press too hard to occlude that artery. But do you feel a pulsation, right? Do you feel that pressure wave going through the arteries? So, but if you're not sure you feel a pulse, you need to always assume cardiac arrest. So don't wait, don't recheck, don't debate with your partner like, oh, is that something? Hey, can you check it for me? No, if the patient isn't breathing normally, no pulses, start compressions immediately, because that's going to save the patient's life. Now that you've identified cardiac arrest, now what should you do, right? Chest compressions. Your first move is to locate the correct spot. Now, typically, you're going to go on the lower half of the sternum. On an anatomically flat individual, you'll kind of draw an imaginary line across their a nipple line, so to speak. Your compressions work by rhythmically pressing on the heart between the sternum and the spine, essentially mimicking the heart's pumping action. Okay, this is going to pump that oxygenated blood throughout the body to the brain and the vital organs. But again, the compressions only work if you do them correctly. That means no leaning on the chest during recoil. You need to let that chest fully expand back up to allow passive filling up of the chambers. Keep your elbows locked, straight arm, straight back, shoulders over your hands, and compressing at a rate of 100 to 120 per minute. And then you want to compress to a depth of 2 to 2.4 inches. When your arms get, what if your arms get tired? Well, you need to switch. Okay, every 2 minutes or 5 cycles of CPR, you should switch with your partners to give you a rest. Because bad form, shallow compressions, long pauses, that means less blood to the brain and worse outcomes. So consistency and form are everything here. Now let's focus on 2 key pieces of kind of high quality CPR. Okay, again, that's technique and recoil. Okay, so technique, again, as we talked about, starts with proper hand placement. The heel of one hand on the center of the chest, lower half of the sternum, then the other hand on top. Okay, boom, and we're gonna cover this more in lab. And then in our EMT 900 courses. So keep your elbows locked, shoulders directly over the hands, and use your upper body, not just your arms, to generate power. You really want to hinge at your hips, use your momentum and your body weight to actually compress that chest, versus your arm strength, your biceps, your triceps, your deltoid muscles, because that's going to take a lot more energy to compress that chest. Now, another part where most people mess up is that they don't allow full recoil of that chest, right? So after each compression, you have to let the chest fully return to its normal position. You don't want to kind of be leaning your body weight on that chest at all times, okay? Because that's going to be detrimental to the patient. Because if you don't allow the recoil, the heart can't refill between compressions, and that means no blood flow or minimized blood flow. You also want to maintain what's called a 1-to-1 compression to release ratio. The time you spend pushing down should actually match the time you allow for release. It's smooth and rhythmic, not jerky, jabbing. So think of CPR as kind of like a dance, consistent, powerful, steady. So if you get tired, again, you want to rotate every 2 minutes or about 5 cycles of CPR, one cycle being 30 to 2. Because if your compressions, again, weaken, the patient's chance of survival is going to drop with every single pump. Now, it's important to note, yes, we do have set standards of numbers and depth, so 100 to 120 compressions per minute, depth of 2 to 2.4 inches. But again, most rescuers, especially first-time rescuers, they compress way too slow, way too soft, okay? And that usually has a lot to do with their first time doing CPR on a patient. They're just not expecting to feel what they feel, hear what they hear, because as you're jumping on that, now make no mistake, CPR itself is very traumatic for that patient. You are essentially traumatizing that patient's chest, right? You're jumping on it with a lot of forces. So with that comes cracking, popping, snapping. You're going to hear it. You're going to feel the vibrations on your hands. So a first-time rescuer thinks they're doing something incorrectly. Okay, it's very normal to hear that popping and snapping as you're doing compressions. But what a first-time rescuer does, they feel it, they hear it, they think they're going too hard, they think they're going too fast. So what do? They instinctively slow it down. They don't press as hard, so you're not getting the full amount of blood volume pushed throughout the body. Okay, so it's important to kind of understand that going in, so when you do start feeling and start hearing it, you know it's normal and you can kind of push through it. So it's much better for the patient, their overall outcome, to push hard and to push fast, okay, versus too shallow and too slow. So you're not necessarily going to know exactly what that 2 to 2.4 inch threshold, but harder is better than too shallow. Faster is better than too slow. And now, as we just talked about, it's kind of like a dance. It's a rhythm. So a lot of rescuers will hum a song in their head that is a specific rhythm to the compressions. Okay, you only have to hum it for like 5 seconds because then your body will actually take over. The most popular one by AHA is going to be "Staying Alive" by the Bee Gees. So and then for copyright issues, I'm not going to play it. But you hum that song in your head and get your rhythm, your body in motion, and now you know you're going the appropriate rhythm and appropriate speed. Okay, because that song is about 100 beats per minute. Okay, and any 100 to 120 beat per minute song will work. So now here, let's move it on. This slide shows a visual reminder that the heart sits really just left of center in the chest. Okay, so it's going to be behind the sternum, between the spine and the breastbone. Okay. So when we see center of the chest, we really mean the lower half of that sternum. That's your compression target. And even though the heart is slightly to the left of the center, you don't move your hands off center, okay? Because it's the sternum that acts like a lever compressing the heart backwards into the spine. It's also worth noting that proper compression technique won't just help circulate blood, it's actually going to reduce the risk of injury. So if your hands are too low, you could hit the xiphoid process and cause the liver or abdominal damage. Too high and you're just bouncing off the ribs. So really stick to that middle lower sternum and keep your motion vertical, not at an angle. Yeah, so here's a good representation of that. Now, also, it's important, again, fatigue, okay? So, as I mentioned earlier, the 1-to-1 compression to relaxation ratio, it just means that every time you compress the chest, you should allow an equal amount of time for the chest to rebound. Okay, now, again, that matters because of perfusion. The delivery of oxygenated blood to the organs only happens if that heart has a chance to refill with blood between each compression. So if you're too fast on the downstroke and too quick to release, or worse, you don't release at all, you're really going to starve the heart and brain of circulation. So many modern CPR mannequins and AED trainers, they can actually give you real-time feedback on depth, rate, recoil. So use those whenever possible for training purposes. There are CPR assistive devices we're going to talk about later to ensure you're getting that appropriate depth and speed, but we'll talk about that later. But if you're on scene without that feedback, you just got to train yourself to listen, to feel, and to watch for that chest rise and recoil. So if you don't see the chest returning fully between compressions, you're really not giving the patient what they need to actually survive. So now, when an unconscious patient isn't breathing, right, the tongue is usually the issue, the culprit, so to speak. It slumps backward and it kind of corks the pharynx, so it just blocks it. The quickest fix here is, of course, when spinal trauma is not a concern, is the head tilt chin lift, okay? You press one hand on the forehead to tilt the head back, 2 fingers under the bony part of the chin, push it upwards, okay? that simple motion actually pulls the tongue forward and opens the airway. But trauma changes the rules a little bit. So if the mechanism suggests a cervical injury, there's a fall, a high-speed crash, some type of mechanism, you're going to switch to the jaw thrust maneuver, okay? This is going to keep the head in a neutral alignment. You're going to slide your fingers behind the angles of the jaw. I personally like to put my thumbs on the zygomatic bones as a nice foundation. Because if you just go straight to the jaw, you have a higher chance of just lifting the entire head upwards. So if I'm pushing down on the zygomatic bones, that keeps the head in that neutral position as I'm pushing up the jaw forward, okay? So what you're doing though is you're moving the jaw in kind of like an exaggerated underbite, and that's gonna move the tongue. And the whole point of this is to move the tongue and the jaw forward without manipulating the neck. It's definitely tougher than a head tilt chin lift, and if it doesn't work, you may just have to accept the minimal neck movement. But airway plus spinal protection, again, is the goal here. But really the bottom line is choose the maneuver that protects both the airway and the spine, reassess immediately and regularly. And remember that neither technique works if the mouth is full of vomit, all right? So you do need to suction when it's indicated, then open up the airway. Now, sometimes all the airway needs is gravity, okay? So if your patient is unresponsive but breathing adequately and you ruled out spine, hip, or pelvic injury, you can roll them in the recovery position. That side lying posture actually lets the tongue fall forward and any secretion actually drain out instead of pooling in the throat. It does buy you time, prevents aspiration, and keeps the airway clear while you prepare for transport. The key aspects here is that you need to roll the patient as one singular unit. Shoulders, hips, the head, they should all move together. And then tuck the upper hand under the cheek so the head is supported and slightly flexed forward. It's definitely better to do this in person, but yeah, never use this position if a trauma is suspected. In those cases, you kind of want to do your best to keep them supine with manual airway control and then suction, of course. And then here's a nice picture of it. So notice how the patient is like, their spine is still fairly straight while the head is tilted forward and again on their side. This allows the vomit, blood, mucus to run out of the mouth. So and then having that little hand pillow, so you can see right there under the cheek, that keeps the airway aligned and it's going to prevent the face from pressing against the floor. A good pro tip here is after you roll the patient, take about 10 seconds to reassess respirations, their rate, the depth, and sound. And they can suction again if it's needed. The recovery position, but isn't just a set and forget type situation. You still need to monitor the airway and their breathing continuously because, again, a patient who vomits once can always vomit again. And initially adequate tidal volume can fade without any warning at all. Now the textbook also let me go a little bit. Textbook also reminds us that the hypoxia plus hypercarbia, that's lethal. Okay, so in plain language, too little oxygen and too much carbon dioxide will actually stop a heart faster than either problem by themselves. So if the patient isn't breathing or is gasping, you must take over. Okay, so one rescuer can use a pocket mask with a one-way valve. Two rescuers can deliver higher tidal volumes with a bag mask device. Whichever you choose, it's best to attach oxygen if it's available and give slow, deliberate breaths. 1 second each, just enough to see the chest actually rise. When you actually overinflate the lungs, this actually forces air into the stomach, causing gastric distension, and really reduces the effectiveness of your compressions. It also is going to decrease cardiac output. Now, finally, never forget your barrier device, okay, when you're giving rescue breathing. A mask or a BVM with a one-way valve, it's going to protect you from secretions and during, any type of airborne disease. You can add eye protection and N95, but safety for you, again, means uninterrupted care for the patient at the end of the day. Now, once the airway is actually open, the BVM, the bag valve mask, bag mask ventilation device, ambu bag, whatever you want to call it, that actually becomes your workhorse for ventilations. Okay. Now, for utilizing this device, the two rescuers are kind of ideal here. You'll have one that's going to maintain the two-handed EC seal on the mask. The other squeezes the bag. But again, that's if you have enough resources. Otherwise, you can easily just do it with one rescuer. To be in charge of ventilations. Okay. Now, when you're one rescuer doing a whole CPR evolution, that's where the BVM can be tricky because you have to be at the specific location for the best practices kind of use for it. But that specific arrangement is going to allow delivery of larger tidal volumes. It keeps leaks to the minimum. And again, this is the two rescuer use of the BVM, and really lets compressions resume without delay. Okay. Your technique really matters. Squeeze the bag just enough to see visible chest rise, and that's going to be about 500 to 600 milliliters in adults, and allow a full second for each breath. Okay. Now, for rescue breathings, you're going to ventilate about once every 6 seconds if there is a pulse. Okay. Once an advanced airway is in, you're going to go to also one breath every 6 seconds, but with continuous chest compressions. Okay. Always attach oxygen and an O2 reservoir when you can. It's really how you're going to reach close to 100% oxygen for this patient. Now, you want to watch out for common issues when using a BVM. A improperly fitting mask, hair or facial features can actually break the seal, or squeezing the bag too hard and forcing air into the stomach. Because again, gastric distension can actually lead to like regurgitation, and that means there's a higher aspiration risk. So you really want to do slow and steady, and with a good seal. That's really the formula for effective positive pressure ventilations. Now, next slide. Now, some patients breathe through what's called a tracheal stoma, okay, and that's a surgical opening in the neck, usually because they've had something called a laryngectomy. And in that case, the mouth and nose are really no longer connected to the lungs. So ventilating through the face mask actually won't work. So now what you have to do, you're actually going to remove the mask from the BVM and fit the bag's connector directly over the stoma. Okay. If the opening is small, use a pediatric or an infant mask to create a better seal. But deliver breaths as you would normally, just 1 second each, just to see visible chest rise. Now, sometimes air will leak out of the patient's mouth and nose, but if so, just cover them with a gloved hand and keep the system essentially closed. Also remember that to suction, stomas collect a lot of mucus, and a clogged stoma is no different from an occluded airway, and treat it with the same level of urgency. So this is here's an image of exactly what we're talking about. So note how the provider here places a small mask or a bag connector itself flush against the actual stoma while sealing the patient's nose and their mouth. Okay. A couple of tips here: you keep the patient's neck in a neutral position. Hyperextension can actually kink the tracheal tissues around the stoma, and then suction before you ventilate if there's like thick secretions. Recheck chest rise for every few breaths. If you're not seeing rise, reassess the seal, look for secretions clogging the stoma. So ventilating through a stoma kind of feels strange the first time, but it's purely just physics. Just create a seal, deliver gentle positive pressure, and watch the chest rise. Okay, it's going to be the same rules for different entry points. Now, in a solo rescue, you'll need to do it all, right? Compressions, airway, ventilation. The compression to ventilation ratio is still going to be 30 compressions to 2 breaths. And again, the key is to try your best to minimize interruptions, because each compression has to be hard and fast, right? 100 to 120 per minute, depth of 2 to 2.4 inches, ensuring you allow full chest recoil. Now, after 30 compressions, you're going to perform that head tilt chin lift, jaw thrust maneuver, then give 2 rescue breaths, and then immediately return to compressions. Now, if the patient is pulseless apneic, this cycle is going to continue without delay until help arrives or an AED is ready. So if you haven't already done so, make sure to activate EMS and get an AED as soon as possible. Now, when you're alone, it's easy to rush. Okay. Now, the important thing is you shouldn't. Right. You need to stay deliberate. You need to prioritize quality and make every movement deliberate and every movement count. Okay. Even as a single rescuer, you can make a massive difference in the survival of the patient if you follow this sequence and really just maintain a high quality technique. Now, with two rescuers, right, your efficiency is going to skyrocket. One person handles chest compressions, and the other is going to manage the airway and the ventilations. You're still going to follow that 30-to-2 ratio, but now you can switch roles every 2 minutes or about 5 cycles. Okay. Now, you might be asking yourself, why should you switch, right? And it's really because if you don't, you're gonna feel tired, right? Once you feel tired, your compression quality will start to degrade, right? The depth decreases, your rate slows, and the overall recoil of the chest is gonna suffer. Alternating rescuers really keep compression strong, consistent, and overall effective. Okay, now. Coordination is everything here. So plan your switch ahead of time. Again, ideally during the ventilation window, and try to make the switch in less than 5 seconds. If you're using an AED, you need to reanalyze the rhythm about every 2 minutes and deliver a shock as indicated, resuming compressions immediately after. So two rescuer CPR, it really isn't just about manpower. It's about maximizing performance, minimizing interruptions. So work as a team, communicate clearly, and deliver care that's sharp, fast, and just relentless. Now, manual compressions are essentially the gold standard, but there are devices designed to assist with circulation, especially when resources are limited or CPR is prolonged. There are two specific. We have what's called active compression decompression, so an ACD CPR. This technique actually uses a device with a suction cup that's actually placed on the chest. After compressing, the rescuer actively pulls the chest back up to its neutral position. So this actually helps create a negative intrathoracic pressure, increasing blood return to the heart between each compression. The added recoil actually will enhance the overall patient's cardiac output. Then we have an impedance threshold device. This is a valve that's actually placed between the BVM and the airway that limits airflow during chest recoil. So this increases the vacuum effect inside the chest and draws more blood into the heart. It's typically used alongside an ACD CPR for maximum benefit. Now, these are advanced kind of adjuncts. They're not substitutes for quality manual CPR. Their benefit largely depends on the correct application and the rescuer familiarity. So if your system uses them, you need to train with them regularly and deploy them only when they won't delay or interfere with the compressions. Now, this specific slide shows us a visual reference of those two devices that we just discussed. 14-17 shows the ACD, the active compression decompression device, typically featuring, again, a suction cup and a handle. Each compression, you pull up on the handle and creates a negative pressure, drawing more blood back into the heart. This helps improve cardiac filling and overall coronary perfusion. Then we have 14-18. This shows the impedance threshold device. This valve fits between, again, that airway device and a bag mask. During the recoil phase, it temporarily blocks air from entering the lungs, which, again, is going to increase negative intrathoracic pressure, drawing venous blood back into the chest and improving the patient's preload. So when it's used together, these tools can actually significantly enhance circulation, but really only when they're applied correctly and, again, without delaying your manual CPR. Now, if your EMS agency stocks these devices, make sure, again, you practice and train with them regularly. The last place you want to read the instructions is actually on the scene, okay? You really need to train like it's real life because when it's you, you won't have time to actually hesitate. Now, in prolonged resuscitation attempts, or when CPR has been it happens in like really tight spaces, like a moving ambulance, manual compressions actually can be hard to sustain. And that's where mechanical CPR devices actually come into play. One option is a mechanical piston-like device. This is a backboard-mounted plunger that actually delivers compressions using compressed gas or electric power. You can set the compression depth, the rate, and the machine does all the work, really freeing up rescuers for airway management or medication delivery. The one that you're going to see a lot out here is the Lucas machine, and we'll talk more about that in lab. But another is a load distributing band. It's also called a vest CPR. This device actually wraps around the patient's chest and tightens rhythmically to compress the thorax. It's lighter, easier to apply than a piston, and also frees your hands for other tasks. But again, remember, manual CPR remains the standard of care. These devices are only used when they've been well trained on and won't interrupt the immediate start of compressions. So if it takes longer than 10 to 15 seconds to set up, you're probably better off sticking with the manual CPR until there's a safe moment to deploy the machine. And yeah, here's what it looks like. Now, again, this is the load distributing band in action. So you'll see it as a it has circumferential straps that tightens and releases with each compression. So this is not the Lucas, but this is the other machine. The benefit of this design is really that it applies pressure across a broader surface area than manual compressions, which in theory potentially improves the consistency and minimizes rib fractures. The band itself is controlled electronically, pneumatically, depending on the model. Once it activates, it delivers compressions again at a preset depth and rate. And again, that's going to free you up to manage the airway, defib the patient, help with medications, and all without compromising the patient's circulation. But still, timing and placement are essential for utilizing these tools. If you're not practiced at it, if you don't practice at applying it, you're going to risk long pauses and just poor outcomes. So if your agency uses them, make sure you make sure your team actually drills with them regularly, because in the end, the device is only as effective as the team that's actually using it. So let's go ahead and shift gears a little bit, and let's go to pediatric CPR. Starting with the big difference that we kind of talked about. Most cardiac arrests in infants and pediatrics begin with respiratory failure, again, not cardiac causes. So that really just means that the primary problem is just an overall lack of oxygenation. And if we don't reverse that fast enough, the heart's going to stop and it's going to stay stopped. So while the basic CPR steps are similar, your emphasis is going to shift in pediatric cases. You still need to push hard and fast, but the airway and breathing is going to take on a greater importance overall. That's why really when you encounter a pulseless child or infant, especially if it's unwitnessed collapse, you just kind of come upon them, your first step should really be include effective ventilations alongside with compressions. Getting oxygen into that system early is really how we prevent arrest from progressing, or sometimes it can actually reverse it entirely. So keep this in mind in the kids. Fix the airway to protect the heart. Okay. And now in your adults, it's often the opposite, right? Start the compressions to protect the brain. So you need to tailor your approach based on the patient's age, their size, and the etiology of the actual arrest. Now, pediatric cardiac arrest doesn't come out of nowhere typically. Most cases stem from an underlying respiratory issue or some other non-cardiac cause. So some of the most common triggers, you have trauma, anything to the head, the chest, internal bleeding. You have infections like pneumonia or sepsis. A big one is a foreign body airway obstruction, especially in our toddlers. Drowning, like submersion injuries, electrocution, poisonings or overdoses. And then in infants, unfortunately, we have to consider sudden infant death syndrome, which is SIDS. But honestly, what these all have kind of in common they often cause hypoxia first, okay, then bradycardia, and finally a full arrest. So this sequence is why the AHA, American Heart Association, emphasizes immediate oxygenation and ventilation in our pediatric BLS, because if we intervene early enough, we can actually stop the downward spiral before cardiac arrest actually happens. So in the pediatric world, again, always keep your eyes open for airway compromise, signs of respiratory fatigue, because if you catch those early, you may never need to actually perform CPR. Now, assessing responsiveness in a child is just like with adults, but with kind of a gentler approach. Instead of shaking or shouting, you might just kind of tap the child on the shoulder, speak loudly, "Hey, buddy, are you okay?" Just very loud. But for infants, again, we're gonna tap the soles of their feet, and if there's no immediate response, we need to look for breathing, check for central pulses. Typically, and that's going to be more for our carotid and our femoral pulses in children, or the brachial artery in our infants. Okay, so you're going to place your index and middle. It's kind of like the go-to fingers gently alongside the upper arm, kind of midway between the shoulder and the elbow. So medial aspect underneath the bicep muscle. And again, this should not take any more than 10 seconds. So typically 5 to 10 seconds is where we're kind of shooting for. If the child isn't breathing normally and has no pulses or a pulse below, let's say 60 with signs of poor perfusion, you're going to begin CPR, because really speed is going to be essential here. But so is being calm, right? In those few seconds, you're deciding whether to start compressions, and your decision could be the difference between the life and death of this child. One of the more essential aspects here is understanding the anatomical differences in our pediatric patients and our infant patients, and it's just that they have disproportionately larger heads. Okay, so when they're laid flat, their head actually tends to tilt forward, and that could cause an airway obstruction by hyperflexion. Okay, so to correct this, we use a shoulder roll or a wedge, a towel, blanket, some type of pad underneath the patient's upper back and their shoulders. This is going to elevate the torso and allows the head to rest in a more neutral sniffing position, which is really ideal for keeping the airway open. Now, in our children, it's important to remember that their airways are very, very narrow. They are softer, more easily occluded. So swelling, foreign bodies, poor positioning can actually block the airflow in an instance. That's why airway positioning and maintenance are even more critical in pediatric BLS than actually in adults. So if the child is unconscious, but they're breathing adequately, and there's no trauma is suspected, place them in the recovery position. If the trauma is suspected, maintain the manual C-spine precautions while managing the airway with a jaw thrust and jaw thrust maneuver and appropriate padding under the shoulders. Now, once you confirm the child or infant has a pulse, but they're not breathing adequately, you don't go straight to compressions. You kind of you want to begin rescue breathing. Okay, so the breakdown here is if there is a pulse, you're going to provide one breath every 2 to 3 seconds. Okay, that's about 20 to 30 breaths per minute. If there's no pulse, or again, depending on the protocol, if it's heartbeats under 60 with poor perfusions, you can begin full CPR. You're going to do 30 to 2 ratio for a single rescuer, 15 to 2 ratio when 2 rescuers are present. This is one of the most testable and teachable differences between adult and pediatric BLS. So timing and the ratios really matter. Overventilating can, just like with any patient, can cause gastric distension, decreased cardiac output due to an increase in intrathoracic pressure. So stay smooth, watch for visible chest rise, and match your rhythm to the child's needs, right? So pediatric CPR is fairly delicate, but when it's done right, the outcomes can be incredible. One of the most important aspects for in CPR for metrics is something called chest compression fraction. Okay, this is the percentage of total resuscitation time that compressions are actively being performed. Okay. Now your goal is to have an 80% or higher fraction. So that means for every 10 minutes of CPR, at least 8 of those minutes should be spent doing compressions. Okay. Interruptions are really the enemy of the survival of the patient. So even the brief pauses are going to reduce coronary and cerebral perfusion pressure, and it takes about 5 to 10 compressions just to rebuild that pressure once it has already been lost. So how does this actually impact your transport decisions? Well, if ALS is not available on scene, you may have to initiate transport while continuing the CPR. But again, don't rush the move. You need to coordinate the roles, call for additional help if needed, and make sure CPR continues during transition, like loading, navigating stairs or ambulance movements. Right? You need to plan everything from switching compressors to preparing the AED, all with the goal of avoiding those pauses. Again, resuscitation is like a choreography, not just a random scramble. Now, this slide's going to dive a little bit more into our chest compression fraction. And again, it's one of the biggest indicators for overall CPR quality. There's been studies conducted that having this chest compression fraction below 60% actually significantly reduces survival rates, while that 80% or more can actually double, sometimes triple the chance of a return of spontaneous circulation, which we call ROSC. So how do we actually try to keep those numbers so high? Well, one thing you want to do, you want to have pre-assigned roles before arrival or really early on in that mega code. You want to limit your pulse check to 5 to 10 seconds and then continue compressions while that AED is actually charging. You want to switch compressors quickly, effectively, efficiently. Ideally, again, every 2 minutes, and then with a plan, right? So think of the time you're doing compressions as just money in the survival bank. Every second spent not compressing is the time that the brain and the heart aren't being perfused. And once circulation drops, it takes time. It's going to take several compressions just to build up that pressure to its what it was, right? So protect every second like it matters, because at the end of the day, it does matter. Now, believe it or not, there are times when CPR should not be started at all, okay? And it's your kind of responsibility as an EMT to recognize those times. The first and most important reason is always going to be safety, right? So the scene safety. If it's not safe for you to be there, your partner or your patient, you just don't go in, right? Your safety should always come first. Now, secondly, obvious signs of death, okay? So if a patient is apneic and pulseless and then also shows signs, clear signs of postmortem indicators like rigor mortis, that's where the body is very stiff, which one of the first parts you can look for in that is to try to move the patient's jaw, and if it won't move, it's like locked into place. That's a sign of rigor mortis. Dependent lividity, which we're going to have an image of that in a second. But that's blood pooling in gravity-dependent areas, because again, all the blood vessels in the body dilate once they pass. So blood is just going to start flowing to the most gravity-dependent area. Putrefaction or decomposition, or injuries incompatible with life. So decapitation, incineration, things of that kind of nature. Evisceration of the brain, the heart, and the lungs, like the brain is like literally outside the body, the heart's outside the body, things of that nature. In those situations, CPR is not appropriate, but documentation is vastly important, okay? So if you make the decision not to initiate CPR, you must describe exactly what you observed and refer to your local protocol when required, right? So be specific, be detailed, always be guided by safety and ethical standards. So as I talked about, so here's the dependent lividity picture. So you have a purplish kind of discoloration on the back of the patient, and that's caused by, again, blood settling after the heart has stopped. You can notice how the skin shows pooling in areas not in contact with the ground, and pale kind of blanched areas where the body presses against the floor. This pattern doesn't occur immediately. It takes about 20 to 30 minutes after the patient has, essentially post-mortem to begin developing. So once you see this, you know that the heart hasn't been pumping for a while, and the tissues essentially have undergone irreversible changes. So CPR at this point would be futile. So this image can be unsettling, but again, it's a vital part of field decision making, right? when you see signs like this, don't initiate resuscitation. Instead, begin the process like a post-mortem care, notify the proper authorities, and shift your focus to more scene documentation, family communication, and any follow-up procedures. Now, another very important scenario for when you don't start CPR is when you have a do not resuscitate order. Now, a do not resuscitate order, these are legal documents that are really created by the patient in collaboration with their physician that really outline their wishes to kind of forego CPR or other life-sustaining interventions. So what should you do when a DNR is present? First, you need to actually verify it, right? It's valid. Is it signed? Is it applicable to the current situation? Now, if the document is available, you honor it and don't initiate CPR. If it's not available, or if there's any doubt, you should always start CPR under what's called implied consent until medical direction tells you otherwise. Some states also recognize POLST or MOLST forms. So these they're kind of like advanced directive forms. These expand on DNRs by kind of outlining specific treatments for these patients. Like they can be intubated and have IV fluids, but maybe they don't want CPR, or maybe they want CPR but no electrical medicine, things of that nature. So really understand your local protocol here and just follow your protocol and the local laws. And if there's no form, but the family insists on doing CPR, that's not, if there's no form and the patient's family insists on not doing CPR, like they're just like the mom or dad or something is telling you like, no, they have a DNR. That's not enough for you to withhold CPR. Okay, you need documentation or direct orders from medical control. So when you're in doubt, you need to start resuscitation and again, document thoroughly and just again, seek guidance by contacting medical control. Now, let's say you started CPR, right? You started CPR. Now the question becomes, when is it appropriate to stop CPR? Okay. The HA provides a simple and kind of memorable guide. It's called a stop mnemonic. So the S, the patient starts breathing and has a pulse. Okay, so that's when you get ROSC. Okay, return to spontaneous circulation. T, the patient is transferred to someone of equal or higher medical authority. In this situation, would be you transfer to ALS or hospital staff. O, you're out of strength. Okay, so and physically unable to continue. You've been doing CPR for so long that you become so exhausted you actually pass out. P, a physician actually directs you to stop. Okay, each of these represents a clear, valid reason to end the resuscitative efforts. But just remember, being tired isn't the same as being physically unable to continue. Okay, if fatigue is setting in, you switch with your partner if possible, and never stop CPR just because it's been a while. Okay, that decision belongs to medical control or a physician. If ALS has their own termination of resuscitation protocol, they can call it in the field. You just follow your system's rules, document everything, and protect the patient's dignity throughout this entire process. Now, shifting gears, we're going to go cover a major reversible cause of respiratory arrest, and we call that a foreign body airway obstruction. Okay. In adults, obstructions can occur from relaxation of the throat muscles, which are common in our unresponsive patients, vomiting or regurgitated material, blood from trauma, damaged soft tissue, dentures, large food items. And of course, actual foreign objects like, meat, poorly chewed food. These obstructions often happen during eating or when patients are unconscious and lose their gag reflex. Okay, so if not cleared quickly, the result is hypoxia, bradycardia, and eventually cardiac arrest. So your job is really early recognition. Ask, is the patient speaking? Are they coughing forcefully? If not, if they can't speak, if they can't cough, they can't breathe, now it's time to actually intervene. And we'll talk about the techniques over the next few slides. Now, let's first look at the when and why airway obstructions actually occur. Now, in adults, it's usually during a meal, especially in our older patients, those with kind of dental issues or who consume alcohol or sedatives. In children, actually, airway obstructions can happen during meals or during play. Think small toys, grapes, peanuts, coins. But your assessment, here's kind of the key assessment pieces. If the patient can cough forcefully, they can talk or breathe, we'll call that like a mild obstruction. So it's like a partial airway obstruction. All you do is encourage them to cough and monitor. You don't really have to interfere at all. But if all of a sudden the patient becomes silent, they're trying to cough, nothing's happening, they become cyanotic, they're doing the universal sign for choking, that's what we call a full obstruction, okay, or a severe obstruction. That's when time becomes tissue, right? So you'll need to act quickly with abdominal thrust or chest thrust, depending on the situation. Always watch for signs of deterioration, because again, a mild obstruction can suddenly worsen, and your fast recognition makes all the difference. And now one aspect that probably should be covered pretty soon is going to be about consent. So if the patient is conscious, you as the EMT need to get consent, in this case it'll be probably nonverbal consent, to actually intervene and start those abdominal thrusts. But once the patient goes unconscious, now you'll be covered under implied consent. Now, the difference between mild and severe airway obstructions, that's very important. That's a key difference. And knowing which tells you whether to observe or should you rapidly intervene. So when you're partial obstruction or mild obstruction, you just have to know, hey, can the patient speak and cough, okay? They might wheeze between coughs, but they still have air exchange, and that's the key there. They still have air exchange. So in that case, don't intervene with abdominal thrust, just encourage them to keep coughing. You want to stay close and monitor for signs of deterioration. Supplemental oxygen may be helpful if tolerated, but again, we're not going to go that far just yet. Now, because what you're trying to do for that, encourage them to cough, you're trying to spasm the upper airway, those muscles, kind of to rattle that item up and out or back down the esophagus. But you're also trying to have air from the lungs come up and out through the trachea and start pushing that item with air pressure out and out of the mouth. Now, with a severe airway obstruction, the patient can't speak, cough, they can't breathe. They do the universal sign for choking. Now, they could appear cyanotic at this point, but maybe not. They might have a high-pitched stridor type sound, but maybe not. But they do have kind of a panicked look on their face. These patients are in critical danger, and this is where you have to act immediately. So if they're responsive, you need, again, get that consent. Hey, buddy, you need some help? I'm going to do some abdominal thrusts. They say, they shake their head yes. Now you're able to help. You're going to go behind them and perform abdominal thrusts. So but now, as you're doing the abdominal thrust, you're trying to do a forceful J-hook motion right above the umbilicus, and you're trying to change the air pressures from the intestines, the stomach, and whatnot, have pressure go up the esophagus, and again, push that item out. But that might not work. So all of a sudden, they go unconscious. Now they become unresponsive. You're immediately going to start CPR, okay, with your chest compressions, which can also help dislodge that item. Now, again, clock is ticking and the oxygenation is already compromised. So there's only one real difference you're going to do is that you're going to do your 30 compressions, and then before giving 2 rescue breaths, you're going to look in the mouth to see if you see that object, okay? And we'll talk about that in a little bit. Now, let's kind of go back a little bit to our abdominal thrust maneuver, okay? Now, this is going to be your go-to intervention for a responsive adult, a responsive pediatric, with that severe airway obstruction. So you're going to stand behind the patient. You're going to wrap your arms around their abdomen, make a fist with one hand, and place, again, the thumb side just above the level of the umbilicus, well below the xiphoid process. So we're not that high on the chest. And then grab your other fist with the other hand and deliver quick inward and upward thrust, okay? Again, each thrust is going to increase that pressure inside the abdominal and chest cavity, and that's going to push air from the lungs, the pressure from the stomach, to help expel that actual obstruction. And then you're going to keep on going until the object comes out or the patient becomes unresponsive, okay? or their condition changes in a way that requires a different action. But typically speaking, it's going to be one of those two. Now, if they go unconscious, do your best to get them to the ground. But again, they could just go straight dead weight. So I'll show you a technique that I use in the field when we're in lab. And then get them to the ground and begin CPR, okay? You never leave them unsupported, so you always don't want to just abandon your patient. Just keep on doing your chest compressions, and we'll talk about that. But really, this maneuver is going to save a life, and your quick action can mean the difference between a full recovery or irreversible hypoxia. Now, again, in certain cases, abdominal thrust maneuver is going to be contraindicated or just ineffective. So you'll need to use chest thrusts instead, okay? Now, these are indicated for like your pregnant patients, kind of in the later stages of pregnancy, obese patients where you can't wrap your arms around the abdomen. So the other method here is to stand behind the patient, arms under their armpits, and then make a fist and place it against the center of the sternum. Again, try your best to avoid the xiphoid process. Grasp the fist with the other hand, okay, and then deliver a straight backward thrust towards the spine. So it's like an inverted compression. This technique really generates a lot of pressure, similar to your abdominal thrust, but it's just higher on the thorax, making it safer and more effective in these special populations. But like the abdominal thrust, you continue until the object is expelled or the patient becomes unresponsive. Just really knowing this technique really ensures you're prepared to manage every body type and condition that you may encounter on scene. And here's a good little example of what that would look like. Again, it's essentially abdominal thrust just on the actual chest, right? Same principle, just different location. But you're not going to go inward and up. It's just one solid bone, so you just go straight back. But again, you can see the rescuer positions themselves behind the patient, places their fist on the mid-sternum, and then, again, delivers firm backward thrust directly into the actual chest. Then keep in mind that this is the preferred, again, technique for advanced pregnancy, patients with abdominal or chest obesity, where your standard abdominal thrusts are going to be ineffective or just unsafe for you. Now, again, if this maneuver fails or the patient becomes unresponsive, you're just going to follow the same steps as you would with the severe airway obstructions. Gently lower them to the ground without having them bash their head. Begin CPR. Check the airway after each set of compressions. Your technique here is all about adapting to the patient, really, that's in front of you. Now, again, if a choking patient becomes unresponsive, okay, you immediately switch into CPR mode, right? But with just one important twist. Here's the sequence. So you lower the patient to the ground as careful as possible. Call for help or activate EMS if it's not already, or if you're not EMS in this situation. You immediately start chest compressions, right? We're going to do 30 compressions, same rate, same depth as for CPR. But then after the compressions, you're going to open up their airway, you're going to open up their mouth, and you're going to look inside. If you see an object, you can actually remove it with your fingers, right? So you can actually see it, you can get it out there. But we don't perform what we call blind finger sweeps, okay? So if no object is visible, you don't go around looking for something, okay? After you do that, you see that there's nothing there or you got some stuff out, you're going to attempt 2 ventilations, okay? If those 2 breaths don't produce a visible chest rise, you resume compressions. And then you repeat the cycle of compressions, check airway again, do you see something, scoop, 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 and then try the ventilations again. You're going to keep on doing this until the obstruction is relieved or ALS takes over. This process is really a combination of basic life support and obstruction clearance. Each compression may dislodge the object, and remember, if you don't get the object out, just reassess breathing and pulse. If you get the object out, you're going to reassess breathing, reassess pulse. If the breathing resumes, if there's no pulse and they're not breathing, you're just going to start CPR. If there is a pulse but they're not breathing, we're going to do rescue breathing. So either 1 breath every 6 seconds for our adults, 1 every 2 to 3 seconds for our infant and pediatrics. If there is a pulse and they are breathing, they're just unconscious, we're going to put them in recovery position and just continually reassess. Now, switching gears to our infants. and peds. Again, this is where foreign body airway obstructions are most common, and it's really the top cause of a preventable death. Because kids explore the world with their mouths, okay? They see something like that's can fit in their hand, they're going to see if it can fit in their mouth, okay? Any type of loose change, small toys, grapes, balloons, popcorn, like everything, okay? Those are all like really notorious for choking hazards. But unlike adults, young children don't always show the classic signs of an obstruction, and that can make your assessment skills even more vital, okay? So the primary rule here is if the child is responsive but struggling, let them cough it out, okay? But if the child is silent, cyanotic, unable to breathe, making ineffective efforts, that's, again, a severe airway obstruction, and you got to act quickly. So now, again, for pediatrics, we're going to do abdominal thrusts and whatnot. But for infants under 1 year old, the abdominal thrusts are actually contraindicated. Okay, so instead, you're going to use the back slaps and chest thrusts maneuvers, and we'll talk about it in the next slide. But again, if a child becomes unresponsive, CPR begins just like with adults, with a special adjustment for age and size, just like CPR. But here we have the abdominal thrust on a responsive child. And again, per American Heart Association, I didn't talk about this. I'm much more thorough in our CPR when I do our EMT 900 courses, because we just spend 4 hours talking about CPR. But for I lost my train of thought again. For adults, per American Heart Association, an adult patient is anyone from puberty and above. So it could be 8, 9, 10, 11, 12. How we know that they've gone through puberty has to do with their body hair growth, and then development of secondary sexual characteristics like breast development on our females. So if you see that, you're going to do adult level CPR. Otherwise, our pediatrics is going to be the age of 1 to puberty. So it's going to be that wide range. And then lastly, infant for AHA CPR at least, we're going to go from 0 to 1. But later on in this sequencing semester, we're going to go over neonate resuscitation, and we'll talk a little bit more about that. So that's what you do right when the baby is born. I digress. For patients above 1, we're still going to do our abdominal thrust, right? So you're going to kneel or stand behind the child, depending on their size. Wrap your arms around the child's waist. Again, one fist right above the umbilicus, which is your belly button. And then again, in and up. So your little J hooks. And again, repeat the thrust until the object is expelled or the child becomes unresponsive, okay? And you don't need to be as forceful with the child as you would be with an adult, because again, they have a much smaller anatomy, so you can be a little bit more cautious with how much force, but you still need to make a decent amount, okay? Because again, you got to be cautious. You're generating a lot of internal pressure, and again, while the technique is life-saving, excessive force could cause injury if it's applied incorrectly. So always support the child and be ready to transition to CPR if the obstruction is not relieved. For infants 1 year of age and under, we're never going to use abdominal thrusts. Their abdominal organs are just too fragile. Instead, we're going to do the back slaps and 5 chest thrusts. So, and again, I'm probably going to do a whole video on this, the techniques in lab. But yeah, you're going to hold the patient, the infant, face down along your forearm, so they're going to be resting on your forearm. It's best to be in a seated position for this. Put them on your thigh as well, downward angle. Always support the baby's head, because again, they have no neck musculature. In this situation, they would be responsive still, okay? So they should have some rigidity, some tone. You're going to deliver 5 forceful back slaps. So with your palm of your hand, you're slapping the infant between the shoulder blades. Then after you do 5, you're going to, again, support the head, flip the baby over onto your forearm. I kind of go from left to right, again, downward angle on your thigh. And then you do 5 quick chest thrusts with 2 fingers, just like you would with CPR for the baby, which we're going to cover in a little bit. But it's going to be 1 finger right below the nipple line. And then repeat in sets of 5. So 5 back blows or back slaps, 5 chest thrusts. Okay, you're going to keep on doing that. You're going to keep on doing that until the object is expelled or the infant becomes unresponsive. It's really it's a rhythm you got to get comfortable with. So practice it kind of often. You just got to remember, if the infant does become unresponsive, you need to begin CPR, starting with chest compressions. And again, just like with the adults, you look in the mouth to see something. Okay. If you do see something, you take your little pinky and kind of scoop it out. But really, the sequence saves countless lives, but only if it's performed with confidence and control. You see too many videos of of infants choking and whatnot, and they pass it off to somebody, and they're just kind of doing little tippy taps on the back. That's not enough force to really dislodge the item. So you're gonna feel bad about this, but you got to kind of really get some force behind those back slaps and chest thrusts. So here's kind of what it looks like. This is not too bad. But yeah, so this is going to illustrate the complete foreign body airway obstruction for our infants. Again, image A, you show the infant kind of held face down across the forearm, head lower than the torso. You're supporting the jaw and the chest with your hand while delivering 5 back slaps. Then after the 5, you flip them over, as shown in slide B. And again, babies face up, still angled downward. I know right here it's not showing an angle downward. Yeah, the feet are high, but the head's still also high. So I'd like more of a downward angle. And then do 5 chest thrusts. Again, 2 fingers in the center of the chest, just below the nipple line. Again, alternating sequence, 5, 5, 5, 5. And you're going to keep on going until the object is expelled or the infant becomes unresponsive. Okay. It's vital that your hand supports the infant securely. This isn't just about the thrust, but it's also just maintaining safety so the baby doesn't fall. Okay. Always keep the infant's head lower than the chest. Again, it's going to allow gravity to help dislodge the obstruction. Again, this is one of the highest yield psychomotor skills in BLS for infants. Your muscle memory here is going to save lives. So get this movement into your routine and just practice it often. And we're going to do a bunch of scenarios in class with all sorts of CPR. Now, if your efforts to clear the airway fail and the infant becomes unresponsive, again, immediately begin following the algorithm. Place the patient supine on a firm, flat surface. Typically, you want to put them on like a table or a desk, something that's a nice foundation. You don't like them on the floor, but if that's what you got to do, that's what you got to do. Then you begin your CPR. Now, if you're by yourself, you're going to do 30 compressions and 2 rescue breaths. But if you have a partner, 15 to 2. 15 compressions, 2 rescue breaths. After compressions, again, open the airway, look in the mouth. If you see an object, remove it with your fingers. If you don't see anything, don't do a blind finger sweep. Try to give 2 breaths. Again, each over about 1 to 2 seconds, but again, it's a very small breath because they're so tiny. If you do see chest rise, awesome. If not, then just resume your compressions and repeat the cycle. And then remember, compressions actually help dislodge the object, just like with the adults. But what makes infant cases kind of different is the smaller airway, increased the fragility, and the greater urgency due to the faster desaturation. So you got to really move quickly and confidently, carefully. Continue the sequence until either, again, the object is cleared, infant resumes spontaneous breathing, circulation, or you are relieved by your ALS or higher level of care. There's a couple things I wanted to throw in there. I already forgot though. It's been a long day already. That's okay. There's a couple things about CPR I want to hit on. Like, what do you do if you are by yourself and you start to choke? So that'd be a good one. Oh, yeah. Let's say you have a patient. Now, this is going to go more towards the adult patient. Now, if you have a patient that is very tall, right? When you're doing your abdominal thrust, it's all about leverage because you want to kind of use your legs and to like do that J hook really well. But if you have a really tall person, your arms might be up here to get to their abdomen. So now you're just kind of going like this upwards, and it doesn't really give you a lot of force. So what you could actually do is have the patient get on their knees. You kind of get in a squat behind them, and now you have a whole lot of leverage to do those abdominal thrusts. You never want to kind of get to their level, so don't stand on anything to match their level, because if you're holding on to them doing the abdominal thrusts, if they go unconscious rapidly, you're going to kind of go flying off that chair. So think about that as well. Now, a couple special situations for resuscitation. All right, so starting with an opioid overdose, okay? An opiate is kind of like heroin, fentanyl, prescription pain meds. Those can cause respiratory distress, respiratory depression, and that could lead to cardiac arrest. But again, your priority is a standard BLS care comes first, okay? Even if you have naloxone or Narcan available, you must begin ventilations and chest compressions as needed. Only administer naloxone after resuscitative efforts have started or in conjunction with them, as long as you have the resources. In a lot of your EMS systems, EMTs can administer intranasal naloxone, maybe intramuscular. But remember, if the heart has stopped, Narcan alone is not going to restart it, okay? So you got to maintain oxygenation and perfusion throughout CPR. The drug may reverse respiratory arrest, but again, without compressions, your brain tissue dies. So the key takeaway here is that CPR first, Narcan second. So don't delay BLS just for medication administration. Now, the other one is CPR in pregnant patients. That requires some modifications due to the physiology, if you will, of pregnancy, especially the gravid uterus compressions. The gravid uterus compresses the aorta and the vena cava. So when the patient is supine, and that's going to reduce the blood return to the heart. So here's what you really need to do. If the uterus is above the umbilicus, you got to manually displace it to the left during compressions. Okay, this can be done using like kind of a two-handed technique from the patient's right. And we're going to hit on this more when we get to gynecologic emergencies and doing emergency childbirth and all that fun stuff. But alternatively, one rescuer can tilt the patient onto their left side while using padding or a wedge under the right hip. But again, only if it doesn't really compromise the compressions. The CPR itself, though, follows the standard adult guidelines, 30-2, push hard, push fast, just like with any adults. So now the reason why this matters is because the goal isn't just to save the mom, right? It's to restore circulation to both the mother and the fetus. So without maternal perfusion, the fetus has no chance. And yeah, resuscitation in pregnancy is rare, but when it happens, your confidence and preparation matter more than ever. Now, as EMTs, right? So grief support for family members and loved ones. Yeah. So as EMTs, our role really doesn't end with clinical care. Okay, when resuscitation efforts are underway or have ended unsuccessfully, the emotional well-being of the family becomes just as important as the medical intervention itself. Family members may experience a psychological crisis that can rapidly escalate into a medical one. So they might faint, hyperventilate, inner shock themselves, right? And we're going to talk about a psychogenic shock. So you need to recognize these, or maybe a cardiogenic if they have a heart attack. But I digress. You need to recognize these signs and respond with both, clinical awareness and emotional intelligence. Right. So it's also critical to understand this moment will likely be etched in their memory forever. Okay. So how you act, what you say, your tone of voice, these things stay with people. Okay. So communicate clearly, make eye contact. Use the patient's name. You want to speak slowly, warmly. If the resuscitation is ongoing, keep the family informed throughout. Don't make promises, but let them know what's going to be done and what you're doing. You have something called compassionate transparency. Okay, and that's important in these moments, and it's going to foster trust, dignity, and hopefully closure. Okay, whether the patient survives or not. Now, once these efforts end and or have to be stopped, we enter into kind of a sensitive space where our words and actions are going to matter. Okay, so here's some things how you can support the family. Take them to a quiet, private place if it's possible. Introduce yourselves, anyone with you, and then just use simple and clear language. Avoid euphemisms like passed on. Instead, you just got to be blunt, like I'm sorry your husband has died, right? Speak in a calm, warm, and professional tone. Use appropriate touch if culturally and situationally appropriate, like placing a hand on their shoulder. But that's going to be something in the moment if it feels right to do. But again, expect a wide range of emotions, right? We learned about the stages of grief already. And again, at any point, that's what's going to happen. So a patient could be in shock. denial. They could just be confused. They could be angry. Okay, and remember, silence is okay as well. They could just be like silent, don't want to talk. But sometimes your presence alone is what they need the most, right? So ask if there's a friend, a family member that you can call for them. But never leave the family alone until they're in the care of someone else, whether it's a police officer, a chaplain, hospital staff. Being there isn't just good patient care, it's really good human care, and that's what we're trying to do here. Now, children, however, experience grief differently. They may not understand actually what's happening or why. Some actually may blame themselves. Others may mask their emotions entirely, but they're always observing. So if children are present, just don't ignore them. Use appropriate age language. Allow them to ask questions. Even if the answers are going to be difficult, you don't need to lie to children. Teenagers especially may try to appear strong, but they're going to be deeply impacted here. So if appropriate, gently ask if they'd like to speak or just sit quiet. Also remember that grief doesn't end when you leave the scene, right? Families may replay every single moment of that day, of that instance for years, right? They may never get over it. And it's not really getting over, but it's moving on from it, okay? So how you conduct yourself, whether you showed respect, patience, professionalism, that can help them actually move forward with just peace or with the pain. And then finally, don't neglect your own emotions, okay? That's often overlooked with EMS providers. You are going to be a part of the worst days of people's lives and it could be emotionally jarring, especially when you're dealing with something that kind of connects with you. Maybe a patient kind of reminded you of a family member. A lot of times if you have a child or infant patient, that could stick with you. So there are the critical incident stress debriefings. So it's very important to understand, take care of yourself as well. Because resuscitations, especially unsuccessful ones, they're going to take a toll. You need to talk to your team, your support group. Use available peer-to-peer support group. Caring for yourself allows you to actually keep caring for others. Now, to move on from the sad stuff, CPR itself, like with most of your skills, it's a perishable skill. Okay, so that means you could lose it if you don't use it, so to speak. So you can't afford to only practice it once a year and assume you'll be perfect when it matters. Now, if you're working in the 911 system, you're probably going to do CPR quite often. If you're working in the hospital in the emergency department, you're going to do CPR quite often. But if you're doing IFTs or maybe you're just not working at the moment, you might not do CPR for quite a long time. So as an EMT, you have a professional obligation to really maintain your competency through frequent deliberate practice. Okay, that means participating in mannequin-based simulations, using devices that provide real-time feedback on depth, rate, recoil, and repeating your skill drills until your hands move with precision, even under stress. If your department doesn't require refresher training for more than 2 years, take the initiative yourself, right? Because again, all your credentials, like specifically AHA, you have to recertify every 2 years. Okay, now in those 2 years, you might not do any type of CPR training. And we are moving to kind of a new way of doing CPR training. It's I can't remember what it's called, but it's a continuous CPR training. We were going to start implementing that more and more, but it just ensures that medical providers are just staying on top of their CPR skills. But really what you can do, you can use video modules, you can do in-services if your department has them, or just seek out high fidelity mannequins in your agency if it's provided. Because again, the truth is, when cardiac arrest happens, you won't rise to the occasion, right? You got to fall back on your training. So make sure that the training is solid, it's current, it's frequent, because the lives depend on it, then lives depend on you. So your own confidence is going to be impacted when you have this situation. To have this come to an end, we're going to talk about education and training for the public. Okay, I'm a big proponent of training the public. I do teach AHA CPR and first aid. I've been doing it for 10 years now, and it's just a vital part of being an EMT. And I always recommend EMTs to become instructors, so we can kind of again just branch out and teach the public. So again, as EMTs, I don't think we're just providers. We're educators and we're advocates. Okay, one of the most powerful impacts you can have in your community is to promote and participate in public CPR education. Okay, and the reason why it's so important is because it's the first link in the chain of survival, and that's early recognition and activation of EMS. And it often depends on a bystander, right? So if that bystander is trained in compression-only CPR, the patient's chance of survival increases dramatically. Okay. And a major barrier for the public is that they have a misconception that they must perform mouth to mouth, and that's why back in 2015 AHA came out with hands-only CPR, because it kind of got rid of the stigma of doing mouth to mouth. So that hesitation keeps a lot from acting, right? Because a lot of the public still don't know about that. So your job is to really help change that mindset. Teach them that hands-only CPR, and teach them that it's effective and it's encouraged. So if you get the chance to teach or demonstrate CPR at a school, church, community event, take it, all right? You might be the reason someone survives next week, next year, even decades from now. So you don't have to be an instructor necessarily to make a lasting impact. Just got to be passionate. You just got to be clear, and just always remember that early CPR is going to save lives. And early CPR starts with people like you teaching people like them. Okay. So that brings us to the end of this chapter on BLS resuscitation. This is, again, a very quick snapshot of CPR. There is so much more. I do recommend getting CPR certified. Again, do the BLS healthcare provider certification course. Do the in-person modules. It just makes it so much more interactive and more in-depth. So, again, read the chapters. I'm going to throw in some extra videos of the actual skills in a little bit. But again, I hope you enjoyed our time together, and I will see you next time.